Hello and welcome to Nursing 325, lecture on pain medications, opiates, NSAIDs, and acetaminophen. When we're dealing with pain, we're going to look at 4 types of analgesics. 1, the NSAIDs, first and second generation. 2, the acetaminophen. 3, opiates, and 4, centrally acting non-opiates. Each one is a class in itself. The first 2 analgesics we'll be discussing is surrounding COX-1 and COX-2. What is COX-1 and COX-2? Well, COX-1 is found in most tissues, and they're responsible for homeostasis or protective functions of the body, such as protecting the stomach lining from acid or regulating the kidneys with blood flow. Then there's the COX-2, which is mainly used for tissue injury, which deals with inflammation. And when we're dealing with COX-1 and COX-2, we'll talk about the NSAIDs, which will block COX-1 or COX-2 to either lead to pain relief or protection of the stomach lining, and therefore reducing fever and inflammation. Our first category is going to be NSAIDs, which are non-steroidal anti-inflammatory drugs. This is revolved around suppressing inflammation. It can be used for moderate to mild pain, antipyretic, which is fever reducing, reduces painful menses or menstruations, and also aspirin falls into this category, which inhibits platelet aggregation and serving as an anticoagulant. These are some of the ones that you're familiar with. They both inhibit the COX-1 and COX-2. When dealing with our first generation NSAIDs, such as the Advil, Aleve, ibuprofen, or Toradol, which is the IV form of ibuprofen, we have to talk about the adverse drug reactions that our patients can encounter. Where does this come from? The inhibiting of the COX-1. Remember, COX-1 releases the prostaglandins that protect our gastric and stomach lining. Well, when we block that, now we're going to have the GI upset, the nausea, the vomiting, the heartburn, and the ulcers. So when assessing our clients, we need to determine if this drug is good for them or not. In addition to this, aspirin also falls under that category. Aspirin is that anticoagulant, therefore it's going to stop the platelets from clotting, therefore it increases our chances of bleeding. So we need to assess for bleeding tendencies. Do we have our patient have problems with bleeding of the gums? Do they have blood in their stool? Do they have frequent bloody noses? So we have to determine if this is right for our patient or not, or if we're giving it to our patients, are these side effects too much and their patient can't handle this drug anymore? In addition to that, remember COX-1 also and NSAIDs, they also help with kidney blood flow. So if we're blocking a little bit of that, we need to make sure our kidneys are functioning correctly. And if our kidneys are slowing down and not working, this is not a drug we want to give them. Here on these slides actually shows an assessment of how we would determine if our patient was bleeding or not. The first top left corner is called petechiae, which is bleeding of the capillaries. It is looks like a rash. It's very pinpoint pricks on that. It's not raised or itchy. It usually comes sometimes after you've taken a blood pressure. Then we have a nosebleed, of course, and then you have the coffee ground emesis, which is partially digested blood. It could be from a nosebleed swallowing it, or it could be from a GI ulcer or so, where the blood has not gone through the system yet, therefore it's still sitting there, and you throw it back up, and it's been sitting there half digested, which is more of that brown look to it. We have abdominal bruising, and we have bleeding in the gums. And then the last one is, enter at your own risk, is the melena, or the hematoschissus. Is basically, one is the black tarry stools, and the other one is bright red blood that's associated with lower GI bleeding. Now remember, as we approach nursing, everything we need to ask ourselves is, why are we giving this drug? How are we giving this drug? What are the therapeutic effects from this drug? What are some side effects that can cause it? What do we need to assess for? And then as nurses, what do we need to intervene, and what do we need to teach our clients on? So the next one here is the interventions. We kind of already addressed that. The signs and symptoms of bleeding we discussed. We want to look for any medications to prevent the GI ulcers, such as the antacids or the PPIs. We are also looking for any easy bruising, or there's that picture of petechiae again. We're going to monitor our eyes and nose, remember kidney function, hence leading into our BUN and creatinine levels. As our first generation NSAIDs, you remember that is the Aleve, ibuprofen. The aspirin, they have a lot that are enteric coated, therefore they can't be crushed or chewed. We know that from before. It's that M&M shell on the outside. Remember, going back to your pharmacology lecture on that, why we can't give that or chew it and crush it. A key thing here about this is, remember, if we're giving aspirin or anything that can reduce the fact or increase the chances of bleeding, such as ibuprofen, we do not want our patients to take it 1 week prior to a scheduled surgery. So we want to tell them to stop that so we don't have increased bleeding during the surgery itself. And then, of course, we're monitoring for our therapeutic effects. What do we want? We want to make sure that we have our pain is reduced, our fever is going down, our inflammation is going down as well. Now remember, not only are we giving this to our patients and we're teaching them about this, but we also need to know this as nurses because we don't want to give something that's going to make our patients worse. So whether you do it as a nurse as part of your assessment before you give a med, or whether you're doing it as instructions for the patients, this is all the same thing. You need to note that with first generation NSAIDs, it needs to be taken with food or milk, hence the irritation of the stomach lining. Remember, it's blocking that COX-1. Therefore, we want to make it a little bit easier for them to digest. We want to avoid alcohol. Why? Well, alcohol upsets the stomach. It thins the blood. We don't need to help that along, which leads us into reporting signs and symptoms of bleeding. Going back to the other slide, the nosebleeds, the gum bleeding, the black tarry stools. We need to talk to our patients about that, and we need to make sure that they know when to report those. We also need to talk about urination changing and weight gain. They kind of go hand in hand. Remember COX-1, kidney function, and if we're going to reduce some of that, we might not get good blood flow to the kidneys anymore. In doing so, we might not be diuresing or peeing off like we should be. And in doing that, we actually gain weight. We're gaining weight of water weight and sodium, and we're not actually gaining weight from calories and fat. So if our patient starts to gain weight and they're not peeing as much as they used to, we need to start asking, how's our kidneys working with these drugs now? Which is another reason why we don't give this drug to patients who have kidney problems. And then we have to talk a little bit more about aspirin. Aspirin is a little bit more dangerous in that sense that they can have a toxicity with it if you give too much, and they can overdose on it, as you can say. So aspirin, if you're having the toxicity issues, they have ringing or buzzing in their ears, unwanted sweating, and dizziness. Now make note that most of the NSAIDs are safe in children except for aspirin. We do not give aspirin to children because it can, especially, with viral infections. So children who have viral infections don't get aspirin because they can get Reye syndrome, which can increase swelling of the brain and liver. Majority of kids have viral infections growing up versus bacterial, so we kind of lay off of giving aspirin to kids, but this is why we don't do that and give them as much aspirin in children. You'll see it more in adults. We need to ask ourselves, who can we give this to and what are we looking at? So we already know some of this already. Sometimes it's contraindicated in pregnancy, but it's actually more of a precaution in that sense. We can give aspirin. We start to do it more now prophylactically for preeclampsia in the first some trimester or so of pregnancy. We don't give ibuprofen per se because it actually decreases amniotic fluid. We also can not give certain things for peptic ulcer diseases or bleeding disorders or perioperative. We already talked about that. Older adults, our kidneys start to slow down a little, and then they retain those meds a little longer, and they aren't excreting them as fast. So we have to worry about toxicity in them. And then there's the alcohol disorder as well. H. pylori infections, that is a bacteria in the stomach that can cause ulcers. Why would we want to give them more medications that's going to cause more stomach problems? And then you also have to be careful a lot with NSAIDs and hypertension. So if our patient already has high blood pressure, it does not work well with patients So we actually tell them do not take ibuprofen, do not take some type of aspirin, especially unless it's indicated by your doctor or provider to do so. So again, if the patient's already taking some other anticoagulants or aspirin or other NSAIDs or ACE inhibitors, which you'll learn a little bit more about, those are in regards to hypertensive meds when we go through the perfusion lecture. These are contraindicated, and you'll need to basically kind of see if the patient's safe to have it, if they're getting too much of a good thing or not, and cross-reference that. Now, we focused a lot on COX-1 first generations. Well, there is a second generation NSAIDs, and it's based on a COX-2. It's called Celebrex. It is a prescription only. It's not over the counter, and the reason is it's a little bit more harsh on the system. You can't take it long term. It's just for short bouts to help with the inflammation and injury, because of the high risk for cardiovascular events due to vasoconstriction. So it increases stroke problems, heart attack problems, things like that. But it does decrease the gastric effects on the stomach lining because it's a COX-2, not a COX-1. If a patient is on this, it's usually prescription, and it's usually a shorter term fix. It's not usually long term, and there are multiple doses for that, and it can go from anywhere from just a surgery, injury, tissue injury, all the way up to arthritis. Here's just an example of why we don't do the second generation's NSAIDs, the Celebrex, as much. As you can tell, if we do give this to our patient, what do we need to do? Same thing as the other one, the GI bleeding. We check for gastric reflux or your PPIs. We monitor eyes, nose for kidney function with the BUN and creatinine. And we also need to now watch for those cerebral vascular accidents. So those are your strokes or MIs, the myocardial infarctions, or heart attacks. Remember, the Celebrex can increase the chances of those two compared to the COX-1 with just regular ibuprofen or Advil or Aleve or so forth, Toradol. We are going to give Celebrex the second generation NSAID. We need to take it with low dose aspirin, not high. Still take it with food and milk. It can still upset the stomach. Definitely avoid alcohol, still the bleeding, changes in urination, weight gain. Those are not changed. So once you get that idea for NSAIDs, they're across the board for that class of drug. But the difference between the first generation, second generation is that cardiac component. So remember, you need to check for telling our patients chest pain, shortness of breath, severe headaches, or signs and symptoms of strokes. And that is what we assess for as nurses, as well as telling our patients that they need to be aware of when they go home. The other thing about this is that because it's a second generation, it does have kind of like a contraindication when given with magnesium or aluminum antacids. What are those? Those are your Maalox and your Mylanta, your gas meds. So you don't want to give that at the same time you're taking Celebrex because it will actually enhance the issues. So what we're looking for is to kind of space it out 2 hours in there. It's not that the patient can't still get the antacids, it's just that we just don't want them on top of each other because it's just going to increase those cardiac issues more if we have that with the magnesium and aluminum. Some precautions for Celebrex or the second generation NSAID. Again, pregnancy, kidney or liver problems, bleeding problems, anemia, alcohol, of course. The two newer things on here is asthma or fluconazole that we can see over here. So asthma is because this can actually exacerbate asthmatics and cause more problems with their breathing. We want to double check the drugs that they might be on, Lasix because of their fluid and electrolytes, anticoagulants for the blood and bleeding. But the fluconazole is also, if you're given it with Celebrex, it actually can increase the levels of Celebrex in the bloodstream, causing more of an overdose, and hence doing some of that is causing more of your cardiac problems again and your arrhythmias. Moving on to the next category is acetaminophen or Tylenol. Acetaminophen is in itself its own category for COX inhibitors. It is effects on the central nervous system compared to where we had ibuprofen, Aleve, and Advil was talking about the prostaglandins. This one is actually dealing with primarily the nervous system, the brain, spinal cord, and increasing the pain threshold. So it's different. That's why some people, and most of us, can say you can take Tylenol and ibuprofen at the same time. It is a non-opiate analgesic. It's given for mild to moderate pain. It reduces fever, but it doesn't have the inflammation component on here, kind of like ibuprofen or Aleve or Toradol does. But it does have the COX inhibitor on there as well. But this one is a COX-2 inhibitor. That's why it's not as upsetting to the stomach compared to the COX-1. When giving acetaminophen or Tylenol to our patients, we need to assess for adverse drug reactions. And that, again, is just the liver. So remember, Tylenol is adjusted PO, going back to your pharmacology lecture on that. Your first pass is going through the liver and then excreted through the kidneys. So the biggest thing about medications is how is our liver doing and how is our kidneys doing. The other side effect that has a problem with this is hypertension. It is mostly associated with daily use in females, and as research has shown that it is increased over time. The biggest thing to do about this is to teach our patients about reporting signs and symptoms of overdose, which will go over our blood pressures, and limiting our Tylenol or acetaminophen intake to 4 grams per day, and that's it. And that's assuming you have good kidneys and liver. So acetaminophen or Tylenol, as you can see, comes in many forms: oral, rectal, and now IV. It's great. It comes with max of 4 grams per day, like we said, and as you can see, these are just different ways to give the medication. What are some things we need to know about as nurses to assess, give our interventions, and then teach our patients as well? So we talked about signs and symptoms of overdose. You're not going to kill yourself, as you can say, overdosing with Tylenol or acetaminophen. It's a slow problem against that you can cause severe liver damage within 48 to 72 hours of overdosing on Tylenol. What do we get from that? We get abdominal discomfort, nausea, vomiting, sweating, and diarrhea. And then if you use this for a longer time period, especially in females, you have increased blood pressure issues. So you can have some overdose on acetaminophen, but mostly it's going to cause it to hit about 48 to 72 hours again in the liver. Remember, when we're talking about COX-2 or we're also talking about our liver, we need to talk about what might be contraindicated with that. So again, alcohol, liver, we don't want those two to mix, so we're not going to give this if a patient has alcoholism. And we also have to be careful. Again, there's your hepatic disease, there's your liver function, your renal disease on there, your anemia with your blood problems, hence the warfarin that you have over in the interactions for the drugs. And then we talk about immune suppressants. So these are some things that we need to cross-reference before we give this to our patient or teach them on it. The third category is the central acting non-opiates, or some of you may know it as the tramadol. It is a substance too. It is a controlled substance that needs to be given for pain, written by prescription, short term for this reason. It's given to moderate to severe pain. So Tylenol, ibuprofen's not cutting it. This is what you do. We normally give it to people who have had surgeries, severe tissue damage. And what does it do? It binds to the opioid receptors, just like opiates do, but without this full effect of it. It just blocks the reuptake of norepinephrine and serotonin. Tramadol, being the central active non-opiates, very much mirrors opioid side effects. When we're looking at adverse drug reactions, it has the same effect: the sedation, the dizziness, the respiratory depression, the overdose. We're also looking at headaches, nausea, constipation, just like opiates would be, as well as seizures and urinary retention. When we administer this drug to our patients, we need to monitor them. Remember, if they're ambulating, they're going to be lightheaded or dizzy, so we have to monitor them so they don't injure themselves. If it has the nausea effect, we need to give it with food. Tramadol is a PO med. If it has the respiratory component on it and it causes the dizziness, respiratory depression, just like opiates, we need to have a baseline respiratory rate before we give this drug to make sure that this is safe to give to our patients. And same about monitoring urinary retention. If our patient's eyes and nose and our urinary output is decreasing, is this something we want to give our patients, and making sure that they can tolerate it? When giving the tramadol, you have to note, because it's PO, it takes a while to take effect. It's not IV form. So it's at least 1 hour for pain relief to set in. Keep that in mind if they are actually going to physical therapy or anything else like that. And also note that that's when the side effects will start to kick in as well too. We do not crush this or cut it for extended release medications. Again, going back to the pharmacology lecture at the beginning. So again, since we know that it causes dizziness, sedation, respiratory depression, what do we have to instruct our patients and note also is avoid driving or operating heavy machinery. Sit down if you're lightheaded, careful about changing positions. We discuss about constipation and prophylactic, meaning let's catch it before it becomes a problem. So what are we going to do? Increase their fluid. We're going to increase their fiber in the diet and their activity, meaning we need them to move and walk around. Ambulation is actually help stimulating the gut and constipation. And then only take this medication as needed. As we know, it is addicting. It is a substance too. It is being monitored by the FDA, and it is prescription. So most doctors will only prescribe this as an as-needed short-term basis for pain relief. Again, what is contraindicated with this makes sense. Alcohol, opiates. If you're already on opiates, you won't want to take this. That's too much of a good thing. You're double dipping. You also don't want to do it with alcohol when it's a respiratory depression, anybody with a seizure disorder. But let's also think about what medications could interact with non-opiates like tramadol. You're going to learn this a little bit more in term 6. It's mostly your psychiatric medications, your antidepressants, your SSRIs, your MAOs. Those actually don't work well with tramadol. And last but not least, we're looking at the opiate agonist, which is your morphine, your fentanyl, hydromorphone, methadone. These are things that mimic endorphins. We're very familiar with it. It comes in IV form. It is given in epidurals, IV pushes, drips. It's used for pain relief, sedation. In doing so, it causes that euphoria effect and respiratory depression. Most of us know this already because we've heard about the opioid crisis, but we're dealing with adverse drug reactions, too much of a good thing. So it takes the pain away, but in doing so, it causes respiratory depression, sedation, dizziness, lightheadedness, and drowsiness. We have to be very cautious of this when we give these medications to our patients, and assess our respiratory rate before we start. Assess our blood pressure before we start to make sure we're not making it worse. Assess for constipation, nausea, vomiting. Also note that because of that, it has a high risk to decrease the respiratory rate. It also causes orthostatic hypotension, so meaning it can drop our blood pressure with movement, standing from a sitting or standing position, so we have to be very cautious with that. In addition to that, it has potential for abuse, which we know, and tolerance, the fentanyl crisis in America today. And then urinary retention. So we have to talk about hydration and elimination most of all to make sure and assess those before we give this, or don't continue to give this drug to our patients if it's getting worse. Because we know the adverse drug reaction leads us into the interventions as nurses. So again, we have to ask ourselves what we're going to do, how we're going to give it before we can give it, and what are the side effects and my assessments that I need to determine before I can give this drug. Vital signs, rate, we talked about that. There's your orthostatic hypotension. Bowel function, you don't want to give them more if it's causing constipation. There's your hydration, you want them to void, and this is a very short-term fix, not a long-term thing to be dependent on. How do we give this drug? Oral, IM, IV, sub-Q, rectally, epidural. There are many different routes that you can give for that. Again, need baseline vitals, respiratory rate, Don't alter the release of it. So if it's in the oral form or IV form, know how to give it. Most of us are used to giving the fentanyl or morphine IV push. It's a slow push over 4 to 5 minutes to decrease those side effects. It's usually also diluted in about 5 to 10 milliliters of normal saline as well to help with that, decrease that euphoria and side effects that they can have. What do we need to teach our patients? Same like we always said, it's a short-term fix, not long-term. Don't operate heavy machinery. Void sudden changes in position. Remember that orthostatic hypotension. Here it is to prevent constipation, fluid, fiber, activity, movement, not staying sit still in the bed. You need to walk around. And then if it does cause nausea, we need to take it with food or milk to help with that in the PO form. Who can we give it to or who can we not give it to or watch? It is still given in pregnancies for epidurals, IV push meds, but it does cross the blood-brain barrier to the baby as well. So therefore, we want to make sure that if mom's feeling the side effects, baby would. So we'll take precautions on that. People with renal function problems, remember, we're worried about our kidneys and don't want to build up into the bloodstream. And then older and infants. Why? Because of that exact reason. Older, they can't diurese, the kidney functions decreasing. Infants as well, they have some issues with the medication amounts. What is it contraindicated with our certain medications? CNS depressants, anticholinergics, antihypertensives. So there are certain blood pressure medications as well too that you can't give this with because it will just increase that chances and more hypotension. So when you come across your perfusion lecture, you'll see a little bit more about that. Opiate antagonists, we have to talk about that if we're talking about opiate overdoses. Naloxone is what we mostly see now, and it is the reversal agents of opiates. It's out there. You guys can take a class to carry this in your bag, and you can give it as a nasal spray. It reverses the effects of opiates, as you know. In doing so, the adverse reactions to that causes abstinence syndrome, meaning the pain's going to return, and when it returns full force. So you have to anticipate and prepare for that with your patient. If you give that, you're reversing the pain reaction. It also causes hypertension because we went from hypotension to hyper, vomiting, tremors from all of that, from that pain withdrawal. In doing so, it can cause ventricular arrhythmias and problems with the heart and the ventricles. So we have to be very cautious of this when we do give it. When we're looking at the interventions, of course, what are we going to do? If we're looking at cardiac issues, we're definitely monitoring our vital signs, our blood pressures, and our heart rhythms. When we're looking at it, we can give it IV, IM, sub-Q, and nasal spray, which is the biggest one, and you can carry that in your bag. If we give it IV, you're monitoring your vital signs every 5 to 15 minutes. The effects last 60 to 90 minutes, so it takes a while, which means that patient can be in pain for that entire time. And you can actually have a rebound effect where respiratory depression can reoccur. So be careful with that. So just because you're thinking you're taking that opiate away was just causing respiratory depression, it actually could come back again, and you'll have to see that and be prepared for it. That's why we're assessing for our vital signs. Be prepared to possibly give this multiple times in anywhere from 2 to 3 minute increments that you need to. Who is it contraindicated for, or precautions with opioid-dependent patients? Of course, we know we can give that respiratory depression even that's not from opiates, because if that's not the problem, then we can have other issues and drop their respiratory rate further. And then we have to be careful with seizure disorders or cardiac issues. Remember, we talked about that with the arrhythmias. And then if they're already on opioids, it's going to react to it, which is the whole point of us wanting to give naloxone. But keep that in mind, it's going to interact with them and cause it to take away that receptors, meaning the pain will come back in full force. Now here's a way for you to test yourself.